Dr. Daver, can you speak to some of the ongoing phase 3 trials in AML? What are you most excited about?
At this time, there are numerous ongoing phase 3 studies in acute myeloid leukemia, some in the frontline and some in the relapse setting. In the frontline setting, the ones that I'm most excited about are trials incorporating a novel immunotherapeutic pathway called the CD47 antibody that works through activation of macrophages. These are looking at a very high-risk molecular group of acute myeloid leukemia, the TP53 and adverse cytogenetics, and there are two randomized phase 3s with this agent, one focused on TP53 mutated AML, looking at the azacitidine and magrolimab versus the current standard of care FDA-approved azacitidine venetoclax in TP53 mutated. The other is actually looking at all older unfit AML, so trying to improve on the aza venetoclax doublet with a triplet. So this is looking at aza venetoclax magrolimab versus aza venetoclax placebo. So if both of these trials or either of these trials are positive, then this will lead to incorporation of immunotherapy in the frontline setting in AML, which is exciting and something we have been working towards for the last 10, 15 years. The other phase 3 trials in the frontline setting or in the maintenance setting really that I'm excited about is called the MORPHO Study. This is using a FLT3 inhibitor, gilteritinib, as a maintenance post-transplant. So we know that FLT3 mutated patients respond well when they receive intensive induction FLT3 inhibitor. We still need to take them to transplant because even though the initial response is good, many can relapse. So we usually try to give 2-3 cycles of intensive induction FLT3, move to transplant. And then if we stop there, we still see that about 40% of these patients can relapse in the next 3 years. So this has led to the efforts to add a maintenance FLT3 inhibitor, gilteritinib single agent, post-transplant as a maintenance for 1 to 2 years versus placebo or observation, which has historically been the standard of care. And so this is being looked at in a large phase 3 multi-center study called the MORPHO Study that we hope to get data from in the near future. Another study in the similar design that's being done by the UK cooperative group is looking at maintenance with the oral azacitidine, again, post-transplant for non-FLT3. So similarly, can we overall improve the outcome, not just for FLT3, but the general patient population going to transplant by using the maintenance oral azacitidine post-transplant versus placebo. And in the relapse setting, there is a very novel, unique oral therapy drug called uproleselan, which is a E-selectin inhibitor. And this agent is now being combined with traditional salvage chemotherapy, such as FLAG-IDA, MEC, versus the placebo plus FLAG-IDA or MEC in the relapse setting. And that study's actually been completed to enrollment, and we're hoping to hear data from that in the near future. So these are the major kind of randomized studies focusing on TP53, FLT3, and relapsed refractory AML that we're looking for in the near future, and hopefully could lead to 2 or 3 more new approvals in the AML space. My activation tip for this question is that there are ongoing numerous frontline phase 3 as well as relapsed refractory phase 3 targeted immunotherapy approaches. Specifically among these, we're excited about the CD47 antibodies, magrolimab, the maintenance with gilteritinib in the MORPHO study, as well as relapsed refractory setting use of a E-selectin inhibitor called uproleselan. And hopefully this will lead to approval of the next batch of 3 or 4 drugs, which will further improve outcomes for frontline as well as relapsed AML.